Hi, everyone. Welcome back to the hashtag See Arthritis event at this year's Canadian Rheumatology Association and Arthritis Health Professions Association annual scientific meeting. I'm Cheryl Cohen. I'm the president of Arthritis Consumer Experts, and it is an absolute honor and privilege to be sitting here today with Dr. Joost Swart. Dr. Swart is a board-certified pediatrician immunologist, as well as a rheumatologist. So you come with a dual expertise, which we're really excited to talk to you about. Dr. Swart achieved his medical degree from the University of Groningen and trained as a pediatrician at the VU Medical Center in Amsterdam. Currently, you're working in the largest Dutch group of pediatric rheumatology / immunology based in Utrecht. So welcome to our program, Dr. Swart.
Thank you so much.
Yeah, we're so excited to talk to you. We know, you know that out in the public, most people, when they hear arthritis, they don't hear the early parts of the word. They don't hear juvenile idiopathic. They don't hear rheumatoid. All they hear is the word arthritis, and they immediately package you as someone who has the odd ache and pain. Yeah. If you add juvenile to that, they almost are in disbelief that children get a degenerative immunological, autoimmune type of disease. So I guess let's start there. When you first got involved in rheumatology, what was it that took you down the kids' path versus the adult path? So when you were in your training, what was it that sparked your keen interest, both in immunology and in rheumatology, to go into specializing in arthritis in children?
So in the Netherlands, in fact, it's already you're trained as a pediatrician. So I made that choice up front. So
okay.
I was interested in treating children and helping parents. And then I had these children with JIA and dermatomyositis. I came across them, and I was very intrigued by the disease and also about all the things that they suffered from, and how to improve it, because there was a lot of improvement to be made still. So that's why I got interested in the field. So but I was already in the pediatrics field, really.
Okay, I get it. And describe to us, as a lay audience, the people who are watching our program, Dr. Swart, explain to us the difference and maybe how they complement one another, the immunology side of your expertise with the rheumatology side of your expertise. How do they connect, and why is it important that they connect?
So when I did my fellowship and beyond that as well, we had, for example, the stem cell transplant unit. And when there were no biologics yet for JIA, we transplanted a lot of children. So they got a hematological stem cell transplant for refractory juvenile idiopathic arthritis. So this was already something we did. So that's a real bridge, you can say, between the immunology and the disease JIA, juvenile idiopathic arthritis. And also in our fellowship, we were trained to be immunologists and look at immune deficiencies. There's also a very large overlap in a immune system that's working too hard to focus on, for example, attacking the joints, or sometimes it's not, it's deficient. And but still the remnants of that immune system that's still there can cause a lot of autoimmunity. So a lot of patients with immune deficiency, they also have autoimmunity. And there's this huge overlap in diseases, what we call autoinflammatory syndromes. And in fact, they almost are all, or a lot of these are really genetic disorders in the immune system, but they present themselves as rheumatic disease or fever syndromes. Yeah?
Right.
But there's a huge overlap.
Yeah, that's fascinating. You know, as a layperson myself, but as a health educator in this field, it's often difficult to explain to people out in the public, even within the healthcare system, who are making policy to serve you as a physician and to serve, obviously, your patients. it's sometimes very difficult to explain to people how different juvenile idiopathic arthritis is from adult forms of autoimmune disease. Can you just really briefly, Dr. Swart, explain to our audience why they're different and how they're different? Like
So we have,
it's just not RA in little people, right?
no, it is, no, no, there is this subset of patients that have RA in a younger age, but I think it's around 7% of the
Okay.
whole JIA population. So then the other 93%, they completely have different diseases. And one of the things, for example, that is very different from RA is that they have a 30% risk of getting eye inflammation, for example, uveitis. And that could be, if you don't pick it up early, it could lead to blindness of the eye. And it's also quite different in the kind of joints that are involved. And sometimes it's very, I mean, the young children, they can mask it, that they have joint arthritis. So they just don't use, for example, their wrist, but you don't see it. If they're 2-year-old, you might miss it. So sometimes they come on at a very late stage. So it's completely different from
Yeah,
a person that,
it's amazing what kids do to try to fit in, right? Not to
yeah,
stand out. So they'll hide
yeah,
pain, they'll hide an inability to do something out in
certainly,
the
yeah, yeah.
playground. Yeah,
It's very hard to see. And then,
yeah,
of course, if for example, physiotherapist picks it up, so this is, and then the ball is rolling, and
yeah.
the diagnosis will be made.
On average, Dr. Swart, how long does it take? I mean, initially, it's the parent who needs to agitate to get to their family physician and to say, well, something's not right with little Susie or little Johnny. How is it this? Is it true that in JIA or in other autoimmune diseases in childhood, is there a delay to diagnosis that is often common in some of the adult forms of the disease?
Yeah, yes, the diagnostic delay is larger, it's longer because, for example, a lot of, and I think we need to educate the GPs and all the and pediatricians of the future. So that's our task. But anyway, or a lot of doctors still think that if the blood's okay and they're looking for inflammatory markers and they're looking for rheumatoid factor, and the inflammatory markers are not high, which is very common in JIA. So you don't see it in the blood, but they still have the inflamed joints. And rheumatoid factor, that's the RA in the children, but that's only the subset of the 7%. So
Right.
you cannot trust your blood work and analysis to say this is JIA or not. So, but we see it, unfortunately, many times that there's this delay because the blood work was fine.
Yeah. Yeah. I think this is the biggest challenge we have as educators is explaining to people that a positive, for example, in adult rheumatology, a positive rheumatoid factor, half the population has a test positive, but doesn't have RA. So
Yeah,
it's the skill of the physician, in your case, the parent who notices a change in their
yeah.
child, and then your skill and expertise in the physical exam. I often say that rheumatologists, pediatric or adult, you're the unsung heroes of the specialty world because you don't have some fancy test that helps you in many ways. It is literally this interview you have with the child, the parent, the skilled exam that you and your colleagues administer to the child, and questions that you ask the parent that really detects these diseases at their
That's
earliest
all we
stages.
need, but that's all we
Yeah,
use really for the
yeah,
diagnosis. We
yeah,
indeed need the duration and there needs to be a joint that is inflamed
yeah.
to be certain of the diagnosis. Yeah.
Dr. Swart, tell us about this year's presentation at the CRA HPA meeting. Why don't you just spend a couple of minutes and give us the high level sort of key takeaways that you gave the rheumatology office, but this time I'm going to ask you to deliver them in lay friendly language, if you could.
So certainly. So I looked at the different treatment strategies for JIA. So what we have a lot of recommendations and treatment guidelines, they still depend on a step-up approach, which means that you have to first start a mild medication, and if that doesn't work, you will escalate to a more intense therapy, and then afterwards you will go for another one. So I think this is the normal procedure that we use a lot of times, and but that could mean also a delay in effect.
Yes.
So we know that, for example, methotrexate, 30% of the patients will fail, but yeah, still we first try that, and then it's also a slow acting drug, so you might lose 3 months of time, and of course that's with all the all the complaints with that the patient has with the morning stiffness and pain and things like that. So there are new strategies, and there are some studies that are looking at maybe if we start early on aggressive, so that's called a step down. So you
Yes.
give a high. So, for example, you would start with a biologic right away, and then maybe you can taper that one. And in fact, those kind of studies have not been performed, a lot of them, but I could find at least 3 in the non-systemic JIA, and they are all of them are effective, a little bit more effective in the beginning, but in the end, most of the time, there's not a lot of difference between early aggressive treatment and the other arms. So the other arms, regular step-up
Right.
approach. And mainly, I think that's because that if it doesn't work at 3 months, the regular arm, people will step over to the aggressive therapy. And then in the end, you will not see any difference anymore. So if you want to see the difference, you have to look in the beginning. So anyway, all these aggressive therapies, they are never inferior in these studies. Then you have the third approach, and that's that you are making a treatment target. So you have this, in fact, it's meant as a shared decision. And then you say, okay, at 3 months time, we want to have a composite score, and that composite score is composed of the well-being of the patient, the active joint count, so how many joints are really inflamed, and also the physician global assessment, and that's how severe does the physician think this one is. Because if somebody has a knee and a hip, for example, then there are 2 joints inflamed. But you can also have 2 very small joints of the 5th finger, for example, and those are also 2 joints. But then the physician will say, okay, these 2 fingers, they are not as bad as the hip and the knee, and you will score that in also, which also the patient does themselves. So they themselves will also do it in the well-being score. But that composite score that will be at the start. So how high is this disease activity? And we want to have it 50% down at 3 months, no matter what you start with. So you need to be there at and if you don't make it 50%, then you need to escalate. You need to change your therapy. And then at 6 months, you should be at an acceptable symptom state. So the one or inactive disease rather. And if that's not possible, then you have to have an acceptable symptom state, very low disease activity. And that's very effective. This is treat to target, it's called, but that's in fact, it's not about the medication really. It's about the target and really rigorously recalculate that target every visit, and really it should have consequences. So if you don't reach the target, you have to escalate.
It really the goal of doing doing a lot early, like achieving a really high outcome, becomes the imperative, and that
it becomes the imperative. There's no discussion about it. You didn't make it, we didn't make it, we're not satisfied, you and I as a patient and physician, so now we should move on, not have another 2 months of patient, or just have a little bit higher dose of this drug. No, just completely go for another one.
So this is definitely the approach, obviously, in adult rheumatology as well. But I imagine, Dr. Swart, Um, Even in the adult setting, it's really hard to convince someone with significant onset, let's say definitely by presentation in the moderate to severe kind of category, even in people who are healthcare professionals, Dr. Swart, it's really difficult to get them started right away on therapy. So I'm curious to know how difficult that is, this step down approach, where normally that go a bit slower, start with our maybe less powerful, if you will, less effective perhaps, medicines first. Now you're going to start them way up here. It's difficult to get people started down here on slower therapy. How difficult is it to convince a parent to really step in and hit it hard early rather than the older approach, which is go slower? Do you know what I mean? Like
Of
sometimes
course.
the
Yeah.
go slower
So
approach
yeah,
allows the parent to get comfortable with the diagnosis, but that's not necessarily the best thing to do for your child.
no. So in fact, you want to know, when are we talking about overtreating? So when didn't you really need that
Yeah.
escalation right away or upfront? And then and this is what we want as in our consortium with the Netherlands and Canada, can do it's called. And then you need biomarker guided therapy, really. So you want to know, okay, with these markers in the blood and these clinical characteristics, I have the signature of the patient and the disease, and I already know for, it will never be 100% certain, but maybe it's not the gamble of a 70-30 or a 50-50, but it will be a 90-10 or 95-5% certain that you will not respond to the methotrexate.
Right.
So there's no use in trying. Right, and I think that we will get there for certain within a few years, and already I think the treat to target makes you're not able to slow down anymore as a physician nor as a parent or patient. You should not. In this time, we have such an array of drugs that. Yeah, you shouldn't settle for less really than in every
Absolutely.
disease.
Yeah.
And in fact, this is what we really think, and we don't want drugs used that we probably in the near future will know that aren't effective in that individual. So
Yeah.
you're going to personalized medicine really there.
So in
And we're
other
not
words,
there
if
yet.
you've got all these biomarkers, and that could be a score on a wellness test, it could be a biological kind of marker.
Yeah,
If you've
this is the
got
recommendation.
4, 5, 6 of these, there's almost no guesswork. You've
Yeah,
got to hit it hard
yeah.
early in order to get that person back to sort of normal as quickly as possible.
Yeah, and there's always the question: is there a window of opportunity? So, would it be better to treat heart early? And for a systemic JIA, which is a different subset of patients, they have fever. It's really a different kind of JIA. But in fact, we in Utrecht already start all those patients early on biologics. So we
Okay.
give anti-IL-1 blockade right away. And formerly, we always gave them steroids. And of course, there are a lot of side effects, and
Yeah.
especially in children, also with the growth retardation. And we have now in the majority of these patients, we don't even need steroids anymore because we're starting right away with the IL-1 blockade.
Yeah.
So
Yeah, that's so, what an exciting advance to talk about. And it parallels obviously some of these advances that have been made in adult rheumatology as well. I think one of the challenges around this whole area of research that you've been doing, Dr. Swart, from a policy perspective, is convincing governments to pay for the more expensive thing early.
Exactly. This is, I always say, if the biological would cost as much as a methotrexate, we probably wouldn't even have to have these discussions.
Yeah.
And in fact, this is why in our can do study, the health economy is such a big part, because we are calculating, the health economists are calculating how much are the costs for parents and for children. Also, they have to take off a day from work. they have to drive to the hospital. I mean, all these things we do take into account. And I
Yeah,
think
that's exciting work because for advocacy organizations like ours, it's those types of data that we can take to our elected officials and say, see here, children have a worth. It's not just, and there is a cost to the loss of a child's life or their activities because it's attached to an adult who is their parent or their guardian. So in other words, it's probably, it's the cost in an adult plus, right?
Yes, and that's something that we're, and of course the quality of life is a very important thing. And if you have the first 3 months, for example, if that's much better with early aggressive treatment, that's so much gain. And you can express that in money, really. I'm not a health economist, but there are calculations for that.
Yeah.
And so all these things will be taken into account. And also we do think that, for example, comorbidities or side effects need to be taken into account in what drugs you take. I mean, if you provoke things, for example, uveitis, if it's provoked by a certain drug, or you can protect people from it by another drug. I mean, that's a huge difference.
No kidding. I mean, we're talking about not just the child's ability to run and play and grow at a normal rate the way other children are, but to think about preserving eyesight, preserving other organs and tissues. Like
preventing operations on the eye.
Yeah,
and things like that.
huge. That's fascinating work, and we congratulate you on all that you've accomplished there. We want to sort of try to wind up our conversation a little bit, Dr. Swart. We know you've got an evening and likely dinner waiting for you somewhere in your private jet there.
Yes.
That is the best Zoom background ever, by the way.
In Corona time, you need to find something, right?
I think that's great. You travel in style, as they say. Last two questions are it's one question, but in two parts, and that is, clearly the entire world has been living through the SARS-CoV-2 pandemic. Part one of the question is, how has it impacted you in obviously your research work with your children, with your parent patients, and the care of them? And then the second part of the question, which is related but sort of separate, is what are you telling parents there in the Netherlands about vaccination? How is vaccination in children being managed? Is it not happening? Is it not necessary for kids who are immunocompromised? So let's take that in two parts, if you will.
Okay, so the first question, it did impact our research indeed. So a lot of centers in our You Can Do study, they were not allowed to include new patients, or even there were centers that were not allowed to have regular checkups with their patients if there was no real medical urgency, for example. So certainly that did impact our research, and we have a delay because of it. And also some of our colleagues and I myself also worked on ICUs to help out in these, at least in the first wave. I also have the Corona ICU. And another thing is that, strangely enough, so children, they don't have a lot of problems with the COVID-19, and apparently that has to do with the pulmonary receptor that they don't express as much.
And that's true. And that's true in kids who have JIA or other forms of
also, So we didn't see a lot of problems with our JIA population, not even while they are using their immunosuppressants. So we do not have extra precautionary measures here in the Netherlands for them. And we do advise them to take a vaccine if they're up for it. And to be honest, most of these vaccines are registered for 18 years and older.
Yes.
And of course, if you're 18 years and older, you still call it JIA, so you can be 85 years old and still have JIA. But for the children, I think there's one vaccine that's being registered from 16 years, or they are now trying to register for that age. There are not a lot of these COVID vaccines that have been registered for children.
Yes,
maybe
and
they
I mean, so vaccines go by way of medicines. People start using them off label almost, and you
yeah,
develop a clinical gestalt with that thing in your population, and then all of a sudden it becomes the best practice.
yeah.
But it doesn't follow typically these normal regulatory pathways. Um, if so, how are you advising? So this is audience. This is not medical advice. Let's just be clear. But how do you, Dr. Swart, how are you advising your parents with their
So if
children?
the child is 18 years and older, so I had a few of these questions, 18 years and older, and if they're up for their
Yeah.
vaccination, I would recommend it for sure.
Okay. Okay.
Yeah, that's and I would recommend it to in fact all healthy people as well,
Yeah.
and I think that's the way we get out of this misery.
No kidding.
Yeah,
Yeah.
and I don't see. So we did a lot of vaccination studies, and with other kinds of inactive, because these are inactivated viruses, right? So they're not what we call living vaccines, living viruses, and they are not a problem that you get a flare of your disease. We didn't see it in any of these vaccines, and they're quite immunogenic as well. And of course, you have to prove that normally for a new vaccine as this one.
Right.
So is it as immunogenic? Does it give you as much antibodies as somebody that doesn't have anti-TNF, for example? But I think that those data will come out from adults earlier than we probably have a registration for children with these.
Yeah, I spoke to Dr. Eder, who is at Women's College in Toronto yesterday, and she has a focus in psoriatic arthritis in the adult population, Dr. Swart, and their data showed that there is, there was an increase in people who were admitted to hospital, that psoriatic arthritis was definitely present. So one of the things about these vaccines that is a clear benefit is it keeps people from going to hospital, that it may not prevent you from getting it, but it will prevent you from getting it at a severe enough state that you have to be admitted to hospital, which I think is, for someone like myself, that's a total win.
Certainly. And if
Yeah.
you're really ill from corona, probably everybody will advise you to not take your medicine for your RA.
Yeah.
Yeah, because it's normally immunosuppressants are contraindicated in an active disease, in an active infection. So you will run a risk of a flare of your disease. So I would certainly do all that you can do to prevent to get a real infection. And I think vaccination is really beneficial for that.
Well, Dr. Swart, we really appreciate the time that you've taken to talk to us. I just want to congratulate you on all of the tremendous research work that you do there in Utrecht. Utrecht is a name we see a lot on paper after paper in high impact peer reviewed journals. So we know you're all working hard there, both in the pediatric end of things and in the adult end of things, and that you collaborate with your pediatric rheumatologists around the world. And we have a very strong group here in Canada, as you know. Dr. Laurie Tucker is a frequent guest on our program, as is Kieran Duffy and many others. So we really appreciate all the great care that you give your pediatric patients and their parents, frankly. When you care for the child, you're caring for the parent too.
Yes.
Yeah.
Yes.
So thank you very much for joining us. We appreciate it.
Thank you so much for having me.
We hope that your flight ends nice.
Yeah, I'm waiting for months already to take off. Yeah.
You're perpetually in the air. So thank you very much. And we hope to talk to you again in the future to hear more about your advances.
Thank you so much.
Thank you.
Nice meeting you. Bye.